right, so this is part 3. So we're going to pick right up with cranial nerve 7. Cranial nerve 7 is the facial nerve, and you can see that it has both sensory and motor functions. So the sensory function of the facial nerve is for taste, and the motor function is for the contraction of muscles for facial expressions. So in order to assess the facial nerve, the sensory aspect, we can just apply like a small amount of sugar or something for the patient to taste, maybe salt. We can place this on the anterior 2/3 of the tongue. Again, not necessarily tested routinely, only if the patient is suspected to maybe have some facial nerve injury. So you want them to be able to correctly identify whatever the different types of salt or sweet or whatever the taste, whatever the item is that you place on their tongue. I'm sorry, I got a little confused there. So then the motor function is going to be tested by having the patient to wrinkle their forehead. You can have them to smile. You can have them to frown. You can have them show their teeth, puff out their cheeks. And while they're doing all of this, is you want to look for symmetry. Okay, you want to see that both sides of the facial muscles are intact and they're symmetrical. So if they're puffing out their cheeks, you want to make sure that both sides of the cheeks puff out, as you can see in the picture there. You can also have the patient to maybe try to close their eyes against your resistance. So whereas you just maybe hold your finger over their eye and see if you can feel them trying to open both eyes. All right, the next one's cranial nerve 8. Cranial nerve 8 is the acoustic nerve, sometimes referred to as the vestibulocochlear nerve. This nerve is a sensory function. It's a sensory nerve, and its functions are for hearing and then for the sense of balance. So in order to test for the acoustic nerve function, we can do what is called a hearing acuity test, or what we call a whisper test, where you actually kind of whisper to the patient's ear, back behind them so they can't see you actually talking. There's also the Rhine test or the Rennie test. You're going to hear this termed some different ways. I usually just call it the Rhine, but you test this by taking a tuning fork. So you have to have a tuning fork for this assessment, and you are going to strike it and apply it to the mastoid process, which is behind the ear. And then that is tested, and that's in the bottom picture there. So the way that that's tested or assessed is the air conduction. They should be able to hear the sound with for air conduction, which is beside the ear, longer than they hear it bone conduction, where it's actually placed on that mastoid bone. And again, you see 2 video links at the bottom of the screen. I will post these into the Blackboard course so you all can watch those, and they are really good at explaining and showing how to actually perform these tests. Then there's also the Weber test, which also uses the tuning fork. So the tuning fork is striked, and then it is placed on the center of the forehead, and they should hear the sounds in both ears equally. Now, there's also the Romberg test that is used to test balance. So the Rhine, the whisper test, and the Weber are used to test the actual hearing. The Romberg test is what's used to test for balance. And so we do this by having the patient to stand with their feet together and have their eyes open. And we want to assess for swaying, see if their balance is good. And then you want to have them close their eyes and watch for any swaying. So most individuals do fine with their eyes open, but once they close those eyes, if they have an impairment of cranial nerve 8, then you may see some swaying, or you may even see them get really off balance. So we have to be careful and be sure to stand beside the patient while you are doing that test. All right, cranial nerve 9 is the glossopharyngeal nerve, and it is both a sensory and motor nerve. And you can see oftentimes it's tested along with cranial nerve 10. So we'll talk about the glossopharyngeal first. So the sensory function is for taste, and the motor function is for swallowing movements. So that's how we test the glossopharyngeal cranial nerve 9. So you can have the patient to assess taste. You can have them identify some taste on the back of their tongue, kind of that posterior 1/3 of the tongue. And then the motor aspect, you can test for a gag reflex and then assess their swallowing. Again, not necessarily routinely tested unless we feel like there is some type of major problem. So then cranial nerve 10 is vagus, which is also a sensory and a motor nerve. Sensory is responsible for the throat, larynx, and abdominal organs, and the motor portion is responsible for voice production, also slowing the heart rate and speeding up peristalsis. So in order to test the vagus nerve, you can have the person talk, and you can just listen to them talk. Their voice should not be hoarse, so you want to note the sound of that voice. And then for the motor function, you can have that patient to say ah. So they open their mouth and they say ah, how you do when somebody wants to look at your tonsils, the back of your throat. And then you're watching for the uvula in the back of the throat, and you want to see that uvula remains midline. It should rise up. You kind of moves up once the person makes a sound, but it should not deviate to the side. So a deviated uvula would be considered an abnormal finding, as you can see in the picture on the right hand bottom of the screen. You can also see where the palate kind of drops as well. Cranial nerve 11 is the spinal accessory nerve, and this is going to be a motor nerve, and it is responsible for shoulder and neck movement. In order to assess the spinal accessory nerve, you want to ask the patient to turn their head to each side of their face, and then they can, you can kind of see that they can rotate against your resistance. So see, how much movement that they have. Is it equal? Is their strength equal left and right? And then you can also have the patient to shrug their shoulders while you resist the movement. So if you place your hands on top of their shoulders, you want to see if they can resist against, or if they can raise their shoulders or shrug their shoulders against your resistance. And again, they should be able to do that, and it should be equal bilaterally. And the last cranial nerve is cranial nerve 12, which is the hypoglossal nerve. This is a motor nerve as well, and it's responsible for tongue movements. So to test for cranial nerve 12 function, you can have the patient to basically just protrude their tongue, stick their tongue out. You want to just see that there's no issues with any tremors. They can stick it out, they can protrude it fully, that the tongue remains midline. And so you can see on the screen there, the finding would be that the tongue protrudes midline without tremors. You can also kind of take the tongue and move it side to side and see if they're able to move it side to side. And you can even resist the movement with a tongue blade to see if they can move the tongue side to side as well against the resistance of the tongue blade. And then also you can see there, it says on the screen, you can have them say some words, light, tight, dynamite, and then you want to just note that those words are clear, they're distinct, and that you can hear those words clearly. So again, we do not always assess all 12 cranial nerves. It is important for you to understand and to know how to assess all 12, know what they are, know what type of function they have, and how to assess for those. But typically the ones that we probably assess the most often are 2, 3, 4, 6, and 10. Those are just the ones that we typically do test. But again, you need to know and be aware of how to test all 12 and what all 12 are and the functions that they have. Okay, so that will conclude the cranial nerve assessment part of the neurological assessment. All right, the next part of the neuro assessment is going to be looking at the motor function of the patient. So, any changes in motor functions are can typically be one of the most common neurological symptoms. So, these are oftentimes some of the first symptoms that we see, are the very obvious symptoms that we may see. So, we're going to be looking at the muscles, we're going to be looking at coordination, and we're also going to be looking at movement. So, when you are looking at the patient's muscles, you do want to look at the size, the symmetry, and the strength of those larger muscles, specifically the biceps, the triceps. So size, symmetry, strength. Also, we want to assess and look at range of motion. So you want to kind of look at the tone, look at the bulk of the range of motion. We want to have the patient to move the muscles against air resistance. You want to assess strength by having the patient squeeze your hands or squeeze your fingers. We can test their lower extremities by having them do pedal pushes, where they push their feet against the resistance of our hands. And then you can also have them raise both legs off the bed, and you can test strength by putting a little pressure on top of their shin area, and just seeing that they can raise their legs off the bed and it's equal. So again, you're looking at the size of the muscles, the symmetry, and the strength, and the range of motion. So making sure that each muscle is symmetrical on both sides. Coordination. We're going to be looking at pronation and supination. So can the patient pronate to supinate of their hands to their knees quickly is one way we do that. So have them to pronate their hands, lie them on top of their knees, and can they supinate? So can they turn their palms over onto their knees or their quads quickly? Are they able to do that? Do they have good coordination? We can also have them stand on one foot and then switch. You might have them hop on one foot. That's another example. Again, you kind of have to base your assessment on your patient's ability to be able to do these things, and are they able to do these things safely. You can also have them to take their heel and run it down the shin while they're lying in supine position. So they take their heel and run it down the shin, obviously of the opposite leg. That takes some coordination to be able to do that. So that would be another way to test coordination. Another way to test coordination will be the ability to touch their nose and then touch one of your fingers and then back to their nose. So you hold your finger out in front of them and you say, okay, touch your nose, now touch my finger, and then touch your nose again. So that's another way to assess coordination. And then also there's movement. So you want to assess the patient's gait and their stance. So you just want to have the patient walk to assess their gait. They have a steady gait. They stand upright, or are they hunched over? They have an upright, they have an upright posture. Also, you want to look at some involuntary movements. Do they have any tremors, or do they have any jerking motions? Just some terms that we want to look at. First of all, fasciculations. That's the first term that's up there underneath movement, and that's basically just another term that we use for jerking or tremors. So, like if the patient has any like tics or muscle twitches or any irregular movements, we refer to that as fasciculations. So some other terms to be familiar with: paralysis. This is going to be the loss of use or function of an extremity. So the person cannot use that extremity at all. They're completely paralyzed. Paresis is just a term that means partial paralysis of the body part or of the body. This is going to be a lesser degree of loss of movement than paralysis. Flaccid or flaccidity, you hear that called sometimes, means that there's no motor response in the extremity. So it's going to lack normal muscle tone, and they also often have absent deep tendon reflexes, which we'll talk about reflexes next. And then spastic means there can be sudden involuntary movements with increased reflex responses. So that's kind of opposite of flaccid. So again, those are just some terms that are related to movement that you do want to be familiar with. Okay, so the next area of assessment are the reflexes. So there's some different types of reflexes that we do want to assess. So the first one is the Babinski reflex, which is also referred to as the plantar reflex. I'm going to skip ahead here to show some pictures. So the Babinski reflex, the normal finding is that the toes curl inward. Okay, and you can see that on the left side of the second picture right here. The toes curl inward when the bottom of the foot. So you take an object and strike or stroke the lateral side of the foot from the heel to the toe. Now you remember from OB, in an infant, the Babinski sign is positive, where the toes fan out, and then that should become absent by 1 year. And remember, if it doesn't, then that could indicate they have some type of CNS damage. But in an adult, if a patient has a positive Babinski, that would be evidenced by dorsiflexion of the big toe or fanning of the toes, and that does indicate or could indicate that there's some upper motor neuro damage. So again, that should be negative by the toes curling inward. Okay, for the adult. All right, next we're going to talk about some deep tendon reflexes. So deep tendon reflexes are going to give us information about the function of the reflex arcs and the spinal cord segments. And the deep tendon reflexes are done by tapping a tendon with a reflex hammer. And we're going to talk about different ones. And then you want to just be sure to compare one tendon to the other. Again, compare those bilaterally. We want to look at symmetry. You want to also look at the degree and the speed of the response, and then recovery to the original position. Now, I already have up here how the reflexes are graded. So you can see a 4+ would be a brisk or a hyperactive response. 3+ is a more brisk than normal, but a 2+ is just normal. And then 1+ is low, and then 0 would be absent. So that's just how those are graded. All right, so let's go forward and we'll talk about each of these reflexes. So the first one we're going to talk about is the bicep reflex. So for the bicep reflex, you can see on the screen here how that is assessed, but in words, you're going to have the patient flex their elbow, and then you're going to place your thumb over their bicep tendon. And that's kind of to increase that tendon stretch when you press down on that tendon. Excuse me. And then you're going to strike the thumb with the pointed end of the hammer. And then a normal response would be flexion of the arm at the elbow, or like where they have, it would be like bicep contraction. Okay, that would be a normal response. Okay, the next one is the tricep reflex. The tricep reflex, you want to have the patient hold their arm at a 90-degree angle. So it's kind of dangling because you want the elbow to be up. So if you let the arm dangle, and you're going to tap the tricep tendon with the flat end of the reflex hammer this time, just right above the elbow. And then the normal response would be extension of the elbow, or the triceps are contracting. So that elbow kind of, and if you've ever had your reflexes checked, or if you've seen this done, some people's reflexes are very brisk, and you can get hit. So it's possible that this examiner, so you have to kind of be careful if you don't want to be hit from the patient, because it's a reflex. They can't really control it. All right, the next one is what we call the brachioradialis reflex. And this is going to be just on the kind of that thumb area of the forearm. So you're going to have the patient's arm in a relaxed position, and you're going to palpate the tendon about 3 to 5 centimeters above the wrist. And you can kind of see in the picture here about where that tendon should be. And then you're going to strike the tendon. You can see they're using the flat side of the reflex hammer. And then a lot of times you only see slight movement of the fingers with this, but the fingers should kind of move with this. All right, the next one is the patellar reflex. So the patellar reflex is assessed by the leg hanging freely over the side of the bed or a chair. They can sit in either or. You want to palpate the muscle just above the patella. And then you want to strike the tendon with a flat piece of the reflex hammer just below the knee or just below that patella. And of course, the normal response is extension or kicking of the leg as those quads contract. So probably, if any of you all have had your deep tendon reflexes checked, you definitely probably had your patellar reflex checked. So you can see the knee kicking out there, or the leg kicking out, extending. And the last reflex is the Achilles reflex or the ankle reflex. And so this is going to be assessed by holding the patient's foot in kind of just a slight dorsiflexed position, with and gonna hold that with one of your hands, so kind of at the top of the foot. And then with the reflex hammer, you're going to strike the Achilles tendon, which is just on the back of the foot, with the flat end, usually the flat edge of the hammer. And then the normal response of the Achilles should be plantar flexion of the foot. So the foot should plantar flex. All right, so that is the assessment of the deep tendon reflexes. All right, the next area of assessment is going to be the sensory system assessment. So sensory system, and this one's probably going to be the most difficult to assess. So basically what we're assessing with the sensory system is we're assessing alterations and sensing pain, touch, and temperature. So you can do this by testing on the forehead, the cheek, the hand, the foot, and you can do this by assessing or using light touch with cotton. And then also you can assess temperature by using hot versus cold. And then you can test pain by using sharp and dull sides of a safety pin. So that's the 3 ways that you can test. And then proprioception, which the last one that's listed there on the screen, is being able to be aware of the patient's position, their body position, without looking at it. So you can assess this with having them do their finger to their nose with their eyes closed. You have them close their eyes and say, okay, take your finger and touch it to your nose. Okay, and that tests proprioception, the ability to recognize body position without looking at it. You can also do the heel to shin test, which we talked about this with the motor assessment. But you can, I think we did that with coordination, but you can also see if they're able to take, with their eyes closed, take their heel of one foot and run it down the shin of the other leg, then that can also test for proprioception. You can also take the person's finger and you can move it up and down while their eyes closed, and you want to have the patient tell you which way they're moving it. So have them, lay their hand on a table, stick their finger out, and you take the finger and you move it up and down and have the patient to tell you which way that they are moving it. Okay, and then I have just a few minutes left in this video, and so the last area of assessment is what we refer to as neuro checks. And so pretty much we've already talked about how to assess these areas, but probably for you in clinical, as a student and even as a nurse, the full neurological exam is usually not an appropriate part of the shift-to-shift assessment. So, and it's because it's very time-consuming. So there will be a full video posted I would encourage you all to watch, but it is a little timely just because the neuro assessment is lengthy. So due to time, a lot of times what the doctor may order, depending on the situation, if they've had a fall or if they've had a head injury, is the doctor will order neuro checks, which are a quick neurological assessment. So sometimes these are done as often as 15 minutes. They may be done every hour, so maybe it's every 15 minutes for an hour, then it goes to every 30 minutes for an hour. It just depends, and then sometimes it just becomes an every 4 check or a shift check. So it's just that quicker assessment. So you're going to be looking at level of consciousness. We've already talked about how to assess level of consciousness. You're also going to be looking at orientation. Are they oriented, person, place, and time? You can look at their bilateral muscle strength. We can do this quickly by testing their grips, and then also testing their leg strength by having them push, do the peel pushes, or even do where they can raise their feet and legs off the bed. And again, just assessing, noting if it's equal or unequal, and if they're weak or strong. We also can assess their speech ability. So, is their speech clear, inappropriate, slurred, mumbled? Their ability to follow commands. Are they able to do the things that you ask them to do? Also, you can assess for any involuntary movements. So, do you see any twitches, any tremors? Just noting if those are present. Also, assessing for any, involuntary movements. I said that. And then the pupil response. So, again, we are looking at PERLA, the PERLA. So, you're looking at the size of the pupil in millimeters, and that should be on most people's pen lights have that chart of the different sizes of the pupils, because they do usually require you put the size in if you're doing an actual neuro check. Again, you want to see that they are equal bilaterally. Do they dilate and constrict? When they should constrict with bright light, and they should dilate with dim light. And then you also, again, just seeing that reaction to the light. Also note if that reaction is brisk or sluggish, or if the pupils are fixed. And then again, just if the pupil, if they do constrict normally, then that's just a consensual response. It's just a normal response. So again, if you shine a light on the patient's eyes, they should constrict. So when that light is shined. And then checking for accommodation, which we talked about, again, is the last part of the pupil response, which is the reflex action of the eye. And so you do this again by having the patient focus on an object. And then as it moves closer, you can have them watch your finger, hold it in front of their face, and then you can move your finger toward the patient's face to see if their eyes turn inward, midline, and constrict. And then you can also check it by holding your finger in front of their face about 4 inches, having them focus on an object past you, and then tell them to focus on your finger, which is like 4 inches away. And you can also test the reflex action of the eye at that time as well. So this will conclude the neuro assessment. And again, I'm going to have several videos uploaded. And if that is something that you feel will benefit you, I would not post the videos if I did not feel like they would be beneficial. So if you need more videos or more explanation, especially the Glasgow Coma scale one, I probably would definitely encourage you all to watch that one. But any of these, and if you can find the time, and while you're driving down the road to class, maybe watch or listen to the one that's the full neuro assessment. Okay, so this will conclude the neuro assessment lectures.